If you've been on social media lately or talked to friends about hormone therapy, you've probably heard someone say, "My doctor switched me from pills to a patch." Is it just another health trend, or is there actually science behind this? Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. A recent analysis of prescription data found that between July 2025 and February 2026, estrogen patch use increased by 26%, while vaginal estrogen cream prescriptions increased 15%, and oral estrogen prescriptions continue to decline. So today we're answering the question, why are more women choosing estrogen patches or creams or topical forms, and what should you do? Welcome to another episode of Hump Day Hormones. This is season 2, episode 81.
It's wild. I feel like every time we've said like the 70s, the 80s, I'm like, oh my goodness.
I know.
We're doing it.
It's really crazy. And then I'm like, what do we just keep going like forever? Like we're going to be on here being like, this is episode 582. I mean, I don't know.
We're
guess
here
so.
for it. We're dedicated.
We're just doing whatever we got to do here.
Yes. Okay, so we're talking about today like estrogen patches versus pills, and why is everybody on an estrogen patch? And so this is something we hear all the time and get asked all the time. Patients will say like, my friend's on the patch, or I heard patches are safer, or do pills cause blood clots, or is the patch stronger? And there's not just like one answer for that. I mean, it is all just a very individualized approach. Both transdermal and oral options of estrogen can be great. It's just dependent on the person, honestly, right. and just having a conversation about that. So today we're going to break down the differences of those.
That's right. Yeah, I think it's hard to say like one's better than the other. It's just like, what's the one that's better for you?
Mm-hmm.
And I think obviously we're not the only people talking about this, because there's a nationwide shortage of patches. And so we've been a little bit affected by that here locally in Arkansas, but across the nation, it is a problem. I mean, there've been hilarious TikTok videos about people like meeting in a dark alley and paying off somebody for their estrogen.
Yes.
But we'll get into that too. Like, what happens if you're on a patch and your pharmacy all of a sudden is out of that? What do you do?
Yeah.
So we'll kind of talk about that too. But I think first we'll just start with like, why has patch use increased? And I feel like there's several reasons, but I feel like honestly, it's like the more we know about hormones, the more nuanced this is becoming. But we just understand estrogen so much better today, and we have so many more options available today. So 20 years ago, Premarin, which was made from horse urine, estrogen isolated out of a horse's urine, pregnant mare urine. 20 years ago, I mean, that was the number one prescription. If you were going to write estrogen, it was Premarin. That was around since like the 50s. I mean, that was around for decades. And so it was the most popular, and they kind of had the market cornered on estrogen. But since then, we have, I mean, again, you could go back through the last 80 episodes and listen to us talk about it, but we just have a tremendous amount of research showing about how estrogen enters the body and why that matters, like why it might be different if you're taking a pill versus a patch versus a cream. Not necessarily because one is stronger, but because they are processed differently in our body. And then it's been recognized by multiple studies in the Menopause Society and other medical organizations that transdermal estrogen may have an advantage, while both oral and transdermal are appropriate treatments. So, like, I just don't want anybody to go away from this podcast and be like, oh gosh, she said estrogen pills were bad. I'm not saying that. They're both appropriate treatments, but many experts now favor the transdermal estrogen for women who have specifically cardiovascular or metabolic risk factors because it avoids that first pass metabolism through the liver. And so, we live in the deep South. We live in Arkansas. And so a lot of our patients have cardiovascular and metabolic risk. I mean, just being a menopausal woman and dealing with other menopausal women, I mean, that's the age group. We see lipids increase, we see insulin resistance. So I feel like menopause all by itself puts you at risk for cardiovascular and metabolic disease. And so saying that transdermal is safer in that population, it's like in my head, well, you're like saying then that's safer for menopausal women. So
yeah, because that's every menopausal woman almost.
Everybody.
Yeah.
Yeah. And so, yeah, just so everyone knows, I feel like we're talking about patches a lot here, but there's patches, there's creams, there's shots that go into your subcutaneous fat layer, there's pellets that go into your subcutaneous fat layer. I mean, anything that's basically not a pill. There's vaginal rings that absorb estrogen through the vaginal tissue into your bloodstream. I mean, basically, just if it's not a pill, that's what we're talking about here. It's just an alternative way into the bloodstream. So, and there've been, I mean, that's the problem is we don't have like a randomized trial that compares patches to pills. Like there's not a head to head, like these people are on a patch and these people are on a pill, but we do have several high quality reviews, published 2024 to 2025, as well as like real world studies that have just strengthened the conclusion that topical and not oral is probably more beneficial. There was a 2025 comprehensive evidence review. This was commissioned by the Canadian Drug Agency. They evaluated many studies that compared oral and then many studies that looked also at transdermal. And so kind of putting all that evidence together, their main findings when they compared oral estrogen to transdermal, they showed that transdermal was associated with a lower risk of blood clots, better sleep in some studies. And then they were similar. Oral and transdermal were similar for what they did for hot flashes. I mean, they're both great for that. They're both similar for bone protection. This is funny to me, no convincing difference in breast cancer risk. Yeah, that's because estrogen doesn't cause breast cancers.
Right. Literally.
Yeah. So
thank you for noting the obvious.
Yeah. So oral didn't cause it and neither did transdermal. So there was no difference there. Also, no convincing difference on endometrial or ovarian cancer risk. Also a weird statement because estrogen doesn't cause ovarian cancer.
Right.
We only worry about endometrial cancer in people who are not on progesterone. So both of those are kind of weird statements. But cardiovascular outcomes such as heart attack, stroke, remain less certain, although transdermal appears to be safer in women with cardiovascular risk factors. So just a very well-organized study to say all of those things that you're saying.
And we've talked about it a million times before too, like on the whole cardiovascular side of things. There's such good data about using oral estrogen and the way that it metabolizes through the liver and causes like increased nitric oxide, which is really good for keeping blood vessels open and flexible and all that. So there's actually some really cool benefits there that you may not get with transdermal options. But I think that's kind of looking more of like at a preventative kind of protective mechanism. But if you've already got some established disease there, oral may not be your best option.
Yeah. And I think we go through like each of these things individually. So we'll talk about like blood clots and stroke and cholesterol and diabetes. And we'll go through like each little maybe disease state and how oral versus transdermal might matter. But like you were saying, I mean, there are some benefits to going through the liver as far as reverse cholesterol transport, maybe helping lower your LDL a little bit better. But on the flip side, maybe we raise your triglycerides a little bit. And so it's always a little bit of a trade-off, but like if it just depends like what you're trying to accomplish, right? So if like my number one goal is I want my LDL to be lower and I know that I baseline have a really low cardiovascular risk, I've done a calcium score that's low, or, I know that I'm not, a very high risk kind of person and I'm not worried about a blood clot, I'm really active, all that kind of stuff, then maybe oral's a great choice for you.
Right. Right.
And so, and I also think, and we'll get into this later, but there's nothing that says that you can't be on oral and transdermal. Like you don't have to like pick one. I mean, some people do a little bit of both. And so
I mean, Mary Claire Haver herself is on a combination of a patch and an oral.
If she's doing it, that's all I'm saying.
And her reason literally was for like the lipid profile side of things to add that oral estrogen in. So
yeah, and sometimes we can't get your levels we can't get people to absorb very well transdermally. Sometimes, I mean, sometimes you get their level too high. I mean, it just really is so individualized, and that's why you just have to follow somebody that knows what they're doing or who cares enough to like even ask those kind of questions. So, okay, oral estrogen versus a patch. I mean, it's basically just the delivery system is different, like two roads to the same destination. The whole point is to get estrogen into your bloodstream so that your little estrogen receptors in your bones and your brain and your heart and your everywhere, your vulva, your every bladder, every place we can think of can see that estrogen and then, have that good effect there. So oral estrogen, obviously you're going to swallow the pill. It's going to go into your stomach, into your intestines, and then it's got to go to the liver and be cleared through the liver, then into the bloodstream. So out of the gut and into the bloodstream, you have to go through the liver. So your liver sees the estrogen first, and that is called the first pass metabolism. And so in the pharmacy world, if you hear that word first pass, that's what they're talking about. The liver responds to seeing estrogen by increasing clotting factors, triglycerides, C-reactive protein, and sex hormone binding globulin. Which, I mean, if we just said that in a non-sciencey way, may make it easier to clot. Triglycerides, not good, may cause more plaque in your bloodstream. C-reactive protein, inflammatory, not good. Sex hormone binding globulin, gonna bind up all your hormones. Like, particularly we think of that with testosterone. So going to lower your free testosterone, lower your testosterone availability because you just made more things to bind it up. So, usually we don't want more inflammation. We want every like little ounce of testosterone that we can muster at this stage of the game. And so, if you're getting like really nuanced down there like that, then you're like, well, I don't want those things. Like, how do we just not do any of those things? And that's where,
it's kind of where you look at the transdermal options.
Yeah.
So, like a patch, a gel, a cream, kind of any of those other transdermal options, it delivers estrogen directly through the skin. So, through the skin, into the bloodstream, and then out into the tissues all over your body. So, your liver is not exposed to that initial surge of estrogen, which means it's not going to respond by producing those proteins that we listed up a second ago. And so I mean that's a good thing, right? If you're not having increased clotting factors, triglycerides, inflammatory stuff binding up all of your testosterone.
Yeah. And so why this matters, I mean, I feel like the one everybody talks about so much is the blood clotting risk. And so increased clotting factors, I'm going to get the blood clot. So this is one of the biggest reasons that physicians choose a patch or a cream or whatever is because of this. So multiple observational studies have found that women using transdermal estradiol have little to no increased risk of venous thromboembolism compared to non-users. So basically your risk stays at the baseline. And then oral estrogen has consistently been associated with a slightly higher risk because of its effect on that clotting factor production. And so the biggest study like that probably tells us this is called the Ester study, ESTHER, Ester study. And it was a study of transdermal estradiol and oral estradiol and Premarin. So it used all those different types. And so, but the oral group, basically they didn't like separate it out. It was, they were either on oral estradiol or Premarin. We don't, really know. And then versus a transdermal, they don't make a transdermal Premarin, transdermal estradiol. And so it showed an odds ratio of 4.2. So like, that's like saying it's 4.2 times more likely that you will get a venous thromboembolism on an oral versus a transdermal. And so, at that point, we didn't really know, were they talking about Premarin or estradiol or what in the oral group, but we knew that it was a 4.2 times increased risk. And then it was a 0.9, so less than 1. So that would actually be like a decreased risk on transdermal estradiol users. But since then, they've done follow-up studies comparing Premarin and oral estradiol that show that Premarin carries a much, much higher risk than oral estradiol. And so there are people who really now believe that oral estradiol really may not increase your blood clotting risk that substantially. But, I really haven't seen a convincing study that kind of says that. And so it may not be 4.2 times more. And we'll break down why 4.2 times sounds more dramatic than it really is. But it still may be, above 1 of an odds ratio.
Well, and until that study comes out, like oral estradiol versus oral Premarin, which nobody's going to do that.
Nobody's going to do that.
There would be really no way to know. But I mean, if you just think about it, like it would make more sense that bioidentical oral estradiol would be safer in all the ways compared to horse pee for your hormones, right?
Yeah, I mean, that's just basic common sense.
Yeah.
So odds ratios annoy me in scientific studies because, people who love an odds ratio is like the media, Nightly news flash. Did you know that oral estradiol and Premarin increase your risk of a blood clot 4.2 times? And it's like, okay, let's talk about what that is. The baseline risk for a clot, like you're just living your life normal, is 2 to 3 out of every 10,000 women. And so if you increase that 4 times, that's 8 to 12 out of 10,000. Well, that's still pretty freaking low. So, it's like when we give people fertility medicines and you're like Clomid or, there's ovulation induction medicines, letrozole or Clomid, and you're supposed to counsel them that you increase their risk of multiple pregnancies. And it's like you essentially double their risk for twins and triplets, but it doesn't really matter because triplets are so rare that even if you double your risk, I mean, you went from 1 in 1,000 to 2 in 1,000. So, it's still so low. Such a ridiculous thing to say it that way. But 8 to 12 out of 10,000 is still, low. That's still less than 1% kind of thing. So the absolute increase using oral estrogen is going to equate to about 6 to 9 more blood clots per 10,000 women that use it each year. So we're getting close to the territory where we were for like breast cancer and the WHI. Like we're making big decisions off of 6 to 9 out of 10,000 people. And so, again, like we need to counsel people on these risks, and it is a real thing. And I don't want to be one of those 6 to 9 people, but I just think we need to be like honest about rather than just, scare people completely. So if per individual, your annual risk of a blood clot on oral estrogen is approximately, because 10 out of 10,000, 6 to 9 is about like saying 10 out of 10,000. So that's a 0.1%. So that's your risk.
0.1.
Yeah, 0.1%. So let's say it another way, 99.9% of women taking oral estrogen will not experience a blood clot. And so it's like, that's a much more fair and a much less like fear-mongering, scary way to say it. So just as a comparison, the absolute risk of a blood clot when you're pregnant is about 5 to 20 out of 10,000. Or when you're postpartum, the highest your risk will ever be is 40 to 65 out of 10,000. So we don't tell people not to be postpartum. And so,
or take a birth control pill, or be pregnant or any of that. I mean, all of that kind of puts your risk up higher.
Yeah. So I think we just have to be honest about what that risk is. And I think I'm going to start telling people there's a 99.9% risk you won't have a blood clot.
I mean, let me break it down.
Yeah. And just, I do think that people should understand that in most of the studies that show a risk of a blood clot, you clot within the first 1 to 2 years of using it. So, these women that come in and they're, 60 years old and they've been on oral estrogen for 10 years, and then their family practice doctor told them, you got to stop that, you're going to have a blood clot. It's like, man, if you're just going to have a blood clot on that, you probably would have done that 10 years ago when you first got on it. And so it's definitely not a risk to take somebody off of oral estrogen who's been on it for 10 years.
Right.
Yeah.
Well, and kind of looking at the whole clot risk and everything, like your history matters. So you kind of have to look at like what's your baseline risk.
Right.
Just a general population is 2 to 3 out of 10,000 women per year will have a blood clot. But things that increase that alone, like being obese, having obesity, being overweight, having a prior blood clot, having a clotting disorder. So that is like inherited, a genetic thing, being a smoker, having migraines with aura. So those are all kind of things that you have to take into account too. So if you have like a menopausal person who is obese and smokes, then I mean, their already baseline risk is going to be a little bit higher. So probably not want to use oral for them. But if you've got, a healthy 51-year-old with no other history, I think it's worth discussing for sure.
Yeah. And not that anybody's making their like healthcare decisions off of money, but sometimes we have to. And oral estrogen, if you're already on, a bunch of other medications that you can't come off of and that are expensive, oral estrogen is cheap. Real cheap. So,
like less than $5.
Yeah. Like really, probably anybody can afford it. And so, whereas, patches or creams are maybe $30 to $50, depending on your insurance. And so, there's that difference too. And then I've seen a lot of patients lately that they have MTHFR mutation, or factor 5, or something like that. And so those are technically fall under the realm of blood clotting disorders. For sure, factor 5. MTHFR is like less of a risk of a blood clot than factor 5. But I think anything that's going to like just tip you over a little bit, it's like, why wouldn't we use the safer options that we have available if they're affordable for people?
Yeah, exactly.
So stroke risk, I feel like stroke and clot, you're kind of saying the same thing because most of those strokes happen because of a small clot that broke off and clogged up a vessel. But I feel like stroke risk is really multifactorial. There's so much that goes into that. How much plaque did you have built up? Your age matters. And then the big deal is like the timing of the hormone initiation matters. And so this is what out of the Women's Health Initiative study, they set up. Hormones, Premarin increases your risk of stroke. And so that was one of the things that was the takeaway from it. But the average enrolled person was 63 years old. And so the point is maybe don't start an oral in somebody who already has a bunch of cardiovascular plaque and already has these baseline risks. And so, they will have all that inflammation and blood clotting risk, maybe be more of a setup for a stroke. You wouldn't have that same thing probably in that same patient if they were 50. And so, stroke, the big deal with stroke, don't start orals 10 plus years after menopause, I feel like is the big takeaway point there.
Doesn't mean you can't start hormones at all. It just means it is a nuanced conversation. Don't start orals. We have a million transdermal options available. I mean, it's just a big conversation to have.
Yeah. And then the liver, is so good in so many ways, but I feel like, when we increase that sex hormone binding globulin, I feel like it's a testosterone deal. I feel like we are so wanting to preserve for sure any testosterone that you're going to have. But if we're in the position like we are with a lot of women of trying to optimize their testosterone to make them feel better, well, then the last thing we want to do is decrease their free testosterone by using the liver, or make their metabolic disease worse by adding more inflammation into the system. And so I feel like I said at the beginning, most of our patients probably have a little bit of metabolic disease and insulin resistance and probably have a little bit of elevated triglycerides at baseline. And so we don't want to make that stuff worse.
Right.
Our goal is to make things better. So, and then obesity, like we just talked about, insulin resistance, which goes right along with obesity. So, there's just multiple reasons that you can convince yourself that, probably transdermal is just easier and better. And then at the end of the day, prescribers are going to not worry so much about it. I'm not going to be worried that, oh my gosh, I'm going to give this person estrogen and then they're going to get a blood clot and everything's going to be blamed on me. And so I feel like in the world, if we're trying to get everybody to prescribe hormones, it's like, maybe if I can't convince you to prescribe oral estrogen, you can at least feel comfortable prescribing this transdermal.
Yeah.
So, and then, cholesterol, we talked about this. We see a little bit better improvement with the LDL with oral estrogen, and that has to do with how it promotes basically that bringing cholesterol back to your liver to be gotten rid of. Stimulating the liver is actually good in that situation. But oral can cause a slight increase of triglycerides. So it's is that trade-off really worth it that you lowered your LDL but raised your triglycerides? They're both cardiovascular risk, So, patches are going to have a more neutral effect on our triglycerides, but maybe not help lower our LDL quite as much. So just a little bit of a trade-off. But again, maybe you could do a little bit of both.
That's right. And then cortisol, which we bring up with everything, right? I know, which I feel like this I didn't really know so much about. So oral estrogen can increase your cortisol binding protein. So if that happens, your body tries to compensate and then your adrenals produce more cortisol, which our goal is always to produce less, right? To lower that. So the free level is unchanged, but technically you have more cortisol, your total is going to be higher.
I know. And I think that's a hard thing for most people to understand, but because it's not like that estrogen made you make cortisol, or, that's not it. Your cortisol production comes from that hypothalamic pituitary axis. Something had to tell your adrenals to do that. But yeah, if your body perceives that the cortisol is lower, not because it really is, but because now it's all bound up, then
kind of the same with like sex hormone binding and testosterone. You're binding that up kind of the same way.
And so yeah, the same thing happens with your thyroid too. You increase thyroid binding globulin, which binds up more of your free thyroid hormone. So you may feel more like a low thyroid person, or someone like on Synthroid may all of a sudden need a higher dose of Synthroid because now they're binding up more of that T4. And so that same phenomenon, I mean, it's all those like binding proteins. And then, blood pressure. There's several studies that show that transdermal estrogen may have less effect on blood pressure. So women with hypertension, like most people with menopause, are going to prefer patches.
Same with migraines. A lot of times a patch can just provide a more like stable estrogen level than kind of having that maybe big peak and then a fall with a pill. So, women with migraines tend to do better on a transdermal form of estrogen. This is kind of an area where there's not a lot of solid research, but if we think about it, I mean, it makes sense, right? I mean, just kind of the way that estrogen acts through a patch.
Yeah, I mean, I think the inflammatory stuff is a big deal there too. Like, a lot of migraines are like inflammatory triggers, and so C-reactive protein and cortisol and all that is I mean, really not going to help anything, but migraines specifically.
Right.
Okay, so probably everybody's like, well, I just want to patch then. And that's honestly why we land on that place so often.
Yep.
And the other thing is that they're convenient. So you only have to change a patch twice a week. They do make a once a week option, that I have found is better covered by Medicare, which is really dumb. I have an opinion there, but they do make a weekly patch or a twice weekly patch. The twice weekly is the most popular, I would say, just because of the steadiness of the levels. But there's some downsides to a patch too.
Like skin reactions for sure. The patch has that adhesive on there. And so if you are sensitive to that, I mean, your skin can be like red and itchy, kind of where you put that patch. We've got kind of tips and tricks that can be helpful for that. You can change brands. You can switch to just like an estradiol gel altogether and just like take the adhesive part out of it. So there's ways to work through it. And then also I feel like just some people don't absorb well, through different, which we've talked about, through different options. Sometimes we try them on patches and don't ever get a great level and have got to make some adjustments anyways. So lots of nuanced stuff to have.
I know. The other thing, so I use a patch. The thing that annoys me about the patch is that it almost like is harder to remember. I feel like, I mean, in a way, it would be easier to remember something I need to do every day than being like, shoot, what day is it? And when did I put this on? And I mean, I have to get my patches out of my box and immediately label the wrapper with like, okay, this is Sunday's patch, this is Wednesday's patch, so that I can like remember.
Yeah.
When I get it out of the drawer, I'm like, okay, this is Wednesday. Which I know sounds silly.
No, I have a lot of women say that to me. They're like, I don't know, how am I supposed to remember twice a week?
You think spam caller wants to hear about it?
Yeah, they do. Yeah, they do. Put them on there.
I mean, it's like sometimes hard to remember. The other thing that totally grosses me out, it makes me feel like I'm like my son or something, is you get the brown mark, like a kid with a dirty Band-Aid on. You get the brown marker on the patch just from where you're like clothes lint and whatever. So I mean, it's not that big of a deal when you take the patch off. You just scrub it with the washcloth and it comes right off. But But it is like by that third day, the patch, it's like, that's kind of nasty looking.
Take that thing off.
Yes. And then, okay, what about absorption? I think is the next thing. So this is a common myth is that like either I hear it both ways, like nobody absorbs the patch. And that's probably true on the 0.025. I feel like that's just totally pointless, but, or just like, oh my gosh, the patch gave me crazy levels. And I feel like we can see it both ways.
Yeah. Some people will say like, well, if you're on a high dosed patch, then you should have high levels. No. I mean, it varies so much with everybody. I mean, it matters what your skin is like and how well it absorbs things topically. Yeah. I think you have to measure levels. You have to just draw levels. You can't. Yeah.
And we've done whole episodes about that. Just check your freaking levels. It's not hard.
I mean, I have somebody all the time on the highest dose patch and their estradiol level is still non-existent.
Right.
You know, like they just don't absorb transdermally.
Yeah, your skin said no thank you.
Yeah.
And so, okay, where do we put the patch? I mean, the short answer is like the same place you used to put the tanning bed sticker when you laid in the tanning bed in high school.
The little Playboy bunny, like on your belly.
Yes. You put it right there. That's where you put that patch.
Oh my gosh.
Yes. And so the best evidence, believe it or not, somebody has studied this, but the best evidence was basically the top of your butt or where the Playboy bunny was. From the tanning bed, but peak estradiol levels was 25% higher if you put it back on the top of your butt, with average levels 17% higher back there. So I've been putting mine on my stomach, but I think after reading all this, I'm going to put it on my butt.
And you're just going to have to remember that it's back there, right? Because you're not going to see it. So I might have to like set an alarm, say like, hey, take your old patch off and put your new one on.
Yeah. And I'm going to have to remember there's dirty brown rim back there that needs to be wiped off.
Right. You won't be able to see it.
You won't be able to see it. Yeah. So I have to
I have also like, I have seen this in real life with patients that they had like an okay level on whatever dose patch we had them on. And then I've told them, hey, like apply it to your butt or like your upper hip area or whatever. And you'll see better levels off of that. I've done that with a few patients before. It's pretty cool.
I also read a paper about putting it up here, like right behind on your shoulder blade. And so I think it's also a good idea to rotate sites so that you're not putting the exact same place every single time. And that's going to decrease on that skin irritation and all that. So, yeah, I think we've kind of gone over, is the patch stronger? No, it's not. It's just a different delivery system. And I mean, the goal is not that we need you on the strongest estrogen anyway. Right. I mean, our goal is that we need you on whatever dose we need you to be on to help you. For most people, that's going to be at least 40. We kind of target 50 to 100. We want to, protect your bones and your brain and cardiovascular disease and all the things. And then obviously we want you to feel better. So it's not about, what delivery system can we get that's going to rocket your estrogen level up the highest. It's just what's going to get you to get that level.
Yeah. And then I think there's questions that you can just like ask your provider that you're seeing. Ask if you're a good candidate for oral estrogen or is a patch recommended? Do you have risk factors? If you took oral estrogen, that would maybe intensify those. Which option better fits your lifestyle? I mean, I have got women that are swimmers. They get in the sauna every day. They're in a hot tub. Whatever. I mean, that's included in the conversation. How will we know if my dose is correct? And then should we monitor your levels? Yes and yes. Get your labs checked.
Yeah, that's right. And then we've talked about gel. It's the exact same phenomenon as a patch, except that you have to put a gel on every single day. I do think that there's maybe something to say for like we cover more surface area. So like if you're putting the patch on, it's just the size of the patch. Like for most patches, that's like about a quarter size. When you put the gel on, obviously you can rub it like all down your forearm or wherever you're putting putting it. And so you do cover more surface area. So there's more skin exposed that could then absorb. So I have sometimes seen people not get good levels on a patch and then get good levels on a cream, but or gel. I mean, usually the gel is a little bit more expensive. It's not as well covered by insurance. You could also get compounded cream, but that's for sure not going to be covered by your insurance. And so there is a nationwide shortage of patches, which I think is like, that's good. That's a great problem to have, because that means finally we are not scared of prescribing estrogen patches.
Right.
And just the pharmaceutical company can't keep up. And so that's amazing. Like, I'm glad we have this problem. Finally, someone is listening and prescribing estrogen. So, it's not all brands, it's not all doses. So usually your pharmacy will help you, and they'll find it for you. If they cannot, there's some mail order pharmacies that we can use. We can switch you to a gel. I mean, there are workarounds. It's not like, oh my gosh, my pharmacy's out of my dose and that's it for me.
Yeah.
Obviously, that's not the answer.
Sometimes switch into just a once weekly patch. Yeah, topical gels. And if you're a good candidate, let's just switch to an oral, And sometimes people are like, oh my gosh, that was so cheap. I wish I would have been doing that from the beginning. I'm like, I know, but maybe let's do it for a little bit. And then when patches come back in, we'll switch you back to a patch. But
I sometimes get tired writing these scripts. The next question was, is there ever a situation where I could be on oral and transdermal? And then I answered it myself. Yes, queen.
Clearly, if you don't know, it's all individualized. It's all about what your needs are. It's all about how you're absorbing, what your risk factors are, what all your clotting factors and all of that, your lipid profile. I mean, it's a lot.
I mean, yeah, I don't care if you're on no estrogen at all or if you're on 15 different kinds of estrogen. I personally really don't care. But I mean, it's all about, to me, what your level is and how you feel, and then what all these other factors look like.
Yeah.
Like, what's your testosterone? How's that being affected? What's your lipids? I mean, like literally, you could be on any and all or none.
Yes, but you deserve to know
that
there are a million options out there.
Yes, queen.
Love it. Love it.
Yes. One of the biggest changes in menopause medicine over the past decade isn't that estrogen suddenly became safer. I mean, we've known the same things about estrogen for a really long time, but it's just that we have more options available now, and we are smarter about how we prescribe it. So for many women, transdermal estradiol is going to offer important advantages of avoiding the first pass of the liver metabolism, minimizing effects of clotting proteins, and then minimizing that triglyceride elevation, and then providing a steady hormone delivery system. But that doesn't mean that everybody should go throw their pills away and get on a patch. It just means that the right choice depends on your medical history, your symptoms, your preferences, and your goals. That's what individualized medicine is all about.
That's right. Okay, if today's episode helped answer your questions about estrogen patches, share it with a friend who's been wondering which type of hormone therapy is right for her.
If you haven't already, subscribe to Hump Day Hormones or follow us on social media and YouTube and Spotify and Apple and just all the places. And then listen every Wednesday. We're going to bring you the latest science on hormones, menopause, and women's health. And we're going to explain it in a way that hopefully is just going to make sense and kind of cut through all of this wild stuff that you see out on the internet or hear from your grandma's sister's best friend.
Amen to that.
Okay, y'all have a great week.
Bye.
Bye.